Simon Abrahams. I'm a consultant physiotherapist, and my job today is to talk to you about the hip joint. So what we're going to do, instead of just going through all the manual testing of the hip joint, what we're going to present today is two sections: the subjective examination and the objective examination. The subjective examination is very important, as not only does this allow the patient to tell you exactly where their problem is, but more importantly, debate still remains over the reliability of many of the orthopaedic manual tests when it comes to the hip joint. So to help mitigate this, we do a very good and hopefully a very thorough subjective exam. So, if we've got our patient in front of us, we ask obviously several questions. Things that we ascertain is to ensure that the pain isn't coming from anywhere else in the body. So I generally do ask, do you have any lower back problems, and do you have any problems at the back part of the hip or around your pelvis, i.e. the SIJ? We just obviously wanted to scan any other pathologies, and if there is, I would still examine the lumbar spine, say if it was coming from lumbar spine, and the hip separately, only because we mustn't assume just because they're getting lower back problems and hip problems that it's definitely all related to lower back. There could be two different pathologies, so it is important to examine both. Once we've excluded other pathologies, meaning lumbar spine, SIJ, then one of the first things I look for is age. Age can generally give you an idea of what's going on. So, as an example, in the over 50s, osteoarthritis or degenerative changes tend to be common, so that'd be on my mind. The next thing I'd be thinking about is some form of greater trochanteric syndrome, that being a tendinopathy, or that being some form of gluteal or trochanteric bursitis. The other thing in this age group are hernias. Inguinal hernias and femoral hernias can give groin stroke hip pain. And in rare instances, we never forget the infections and the avascular necrosis as well. So we just need to be aware that there are other pathologies apart from the standard orthopaedic ones. In the under 20s, which is rare, we will be thinking more of the traction and bursitis pathologies, such as anterior superior spine, sartorius, anterior inferior iliac spine, rectus femoris. We'd be thinking more towards quadratus lumborum as it connects to the iliac crest, but also the periphes, which is obviously an avascular close to the femoral head in children, and the big one, SCFE, slipped capital femoral epiphysis. So there are certain pathologies in the kind of teenage years that we know we need to just be aware of. And then in a more sportier person, and that doesn't necessarily mean a runner or a footballer or a rugby player, it could be someone who does a lot of walking, as an example. We need to consider things like osteitis pubis, femoral acetabular impingement, we need to think about sportsman's hernia, we need to think about muscular strains and sprains, of course, and not forgetting stress fractures as well. Now, the next question I tend to ask is, how did it happen? Mechanism of injury. Now, this doesn't tell me too much, apart from the fact that there is no clear mechanism of injury. It's unlikely to be an acute muscular strain or sprain, a ligament muscular strain or sprain. Normally, for muscles to have damage and for ligaments to have damage, there needs to be a clear mechanism of injury. If there's not, then it's unlikely to be one of those ones. I ask the patient to point directly where the pain is. Now, generally, if they point laterally, so we can just see this round here, just run this portion, we need to be thinking about the degenerative changes. We need to think about lumbar spine, SIJ referred. We think about, obviously, gluteal trochanteric syndrome, more so bursal than tendinopathy, as this is more posterior. And then we think about ITB, and maybe in some cases, if they're complaining of neuro symptom, we think about neuralgia paresthesia. On the posterior side, around the back, you'd be considering lumbar spine, you'd be considering sacroiliac joint, would be considering degenerative changes, even though that's more towards the kind of medial and acetabular part of the rim, but would also be considering maybe hamstring issues, muscular issues, sciatic nerve, piriformis pathologies. So more towards the kind of SIJ lumbar spine rather than the hip joint. It's very rare the hip joint generally just refers posteriorly. And then the big one, anterior stroke medial groin pain, so just round there, tends to be common, and this may depict some form of osteitis pubis, femoral acetabular impingement, sportsman's hernia, stress fractures, of course, Again, in rare cases, things like avascular-necrosis, but generally intracapsular pathologies. The other thing that we need to watch out for in elderly patients is they have a full, never discount fractures of the inferior pubic rami. So just around this region here can present itself with anterior groin pain. So we just need to be conscious of that. Notwithstanding, there is also glands in this area, and obviously if they're elevated, that may indicate some form of infection or some sort of inflammation. Now, other questions that we would ask include aggravating easing factors, and if there is no clear aggravating and easing factors, it may be a non-mechanical cause, and we'll talk about that a bit later on. I ask about how long they've had it for, because chronicity gives us an indication of the type of pathology. So if it's 6 months history, that's unlikely to be a muscular strain, that's unlikely to be a ligamentous strain, it's more to do with the joint itself. The other question I ask is about family history. Does any of your family have any hip problems? Do any of your siblings have any hip problems? Brother, sister? The reason why I ask that is we know osteoarthritic changes can occur in families, avascular necrosis can occur in families, but the other thing with regards to hip joint are biomechanical causes. Dysplasic hips, hypermobility, instability can follow in families. So we ask about family history. The next question I ask is 24-hour pattern. I just get an idea of the pain levels first thing in the morning, maybe through to lunchtime, maybe the afternoon and the evening, just to give me an idea of what's going on. So as an example, you know, we know that degenerative changes, osteoarthritis is going to be slightly more stiffer and sore maybe in the morning, and then it frees up. Likewise, if they complain of pain maybe near the end of the day, again that could be some degenerative changes, obviously because they're weight bearing throughout the day depending on what they're doing. But also on top of that, it could be biomechanical as well. So again, give me that 24-hour pattern, gives me an idea. And then I further ask, does that also occur maybe at weekends? Because obviously what they do during the weekday may be different from what they do in the weekend. So it's just trying to work things out. The other thing I ask is, of course, do they have any other joint aches or pains? I just want to exclude any obviously rheumatic pathologies. I want to exclude anything which potentially is biomechanical. Past medical history is also important. Have they had any previous surgery? If they've had surgery on the opposite knee, maybe they're weight bearing more on that particular side. If they've had lumbar spine surgery, it may indicate that obviously there could be a lumbar spine fault. So giving previous surgery history gives an indication of what also again could be going on. One of the most important questions I ask is about any lifestyle changes. Now if a patient says, well, I started developing hip groin pain and I'm not sure how to come on, we may need to go back and search what has changed in the last few months leading up this pain. So, has anything in their job changed? Has anything in their home environment changed? Have they changed shoe wear recently? If they're doing any form of training, have they changed the duration, intensity, frequency of that training? So, we just want to build up a picture of what was happening pre the onset of their pain, because sometimes they won't remember. And if they still can't remember, sometimes I say to them, look, have a little think about it. Go home, and then when you come back to see me again, have a little think about during that period what potentially could have caused it, because you may not remember, in which case you may want to speak to a spouse about it because they may remember. Alternatively, you may pick it up just like that as soon as you walk out and get in the car. So get an idea, because that not only triggered off the potential pathology, but more importantly, unless you resolve that issue, you'll get the hip better, and then it will come back on again because you haven't eradicated that cause. So it is important to try and find out what could have triggered or caused it. The other question I tend to ask is, you know, have they had any recent blood tests, investigations, again just to rule out any infections, any chronic inflammation or any chronic inflammatory markers or anything else that could be going on, and any MRI scans or any previous investigations for hip pain. And again, any changes in recent medicine. One of the things I specifically asked for is antibiotics. The quinones, we know, are commonly used as a general broad spectrum antibiotic, but we know that that can fill up tendinopathies, in particular Achilles, as well as patella, as well as gluteal. So again, just building up that nice picture, making sure there's nothing else that could have triggered off that pain. Now, special questions towards the hip joint need to be specific to the hip joint. So, one of the things I ask is, have you had any recent infections in anywhere in your body recently. Again, A, because if it was treated by antibiotics, that could be a potential cause of a tendinopathy, but B, the joint could be septic arthritis, so we just need to be aware of that. Coughing or sneezing, does that increase any of your hip pain? If coughing and sneezing increases hip pain, that potentially could indicate some form of herniation in the area or lumbar spine referred. We know that if you have a prolapsed disc or space-occupying lesion, this can increase intrathecal pressure within the spinal cord. And when we cough or sneeze, that can not only give us more back pain, but refer down as well. So we just need to be alert that there could be other pathologies there. Clunking. Do they get any distinct clunking on the hip, which may indicate some form of tear, acetabular tear, some sort of osteochondral body, but the other thing is snapping hip syndrome, which is just where the iliopsoas tendon or psoas tendon snaps over one of the eminences of the iliac crest. Does lying on it increase any pain? This is classic in patients with intracapsular pathology, in particular bursitis, so just be aware of that. Again, previous surgery, and I'm not just now talking about orthopedic surgery where the hip, knee, foot, but any gynae ops, any laparoscopies, because we know abdominal issues and gynae issues can refer slightly down towards that hip joint, as an example. In particular in ladies, is there any history of any cystitis? Is there any history of any bladder, recurrent bladder infections? Could they potentially be even pregnant? Ectopic pregnancies we know can give groiny pain. And in gentlemen, when was the last time they had their prostate checked? If obviously they're over a certain age or testicular area, you know, how often do they get that checked? Because we know that can refer also in that particular area. These are obviously sensitive questions, but you do need to ask these questions. And again, any medicines, any changes in medicines, which potentially could have triggered that off. Now, red flags. The red flags would include a severe limp, which may potentially indicate not just an osteoarthritic joint, but maybe an AVN, avascular necrosis, or a potential infection, as well as obviously some form of small fracture. Giving way of the hip. Now, obviously there could be a tear of the acetabulum, which we know is not really a red flag, but if there is some form of cord compression, we know that the leg can give way and they may associate it with the hip joint, so we just need to be aware of that, as well as obviously neurological conditions. Progressive, unrelenting pain is rare and unusual, and that would indicate maybe some form of infection, some sort of fracture, and again, in rare instances, maybe some form of avascular necrosis. Bilateral numb leg numbness or saddle paresthesia, again, may indicate much more central spinal issues, cord equine in particular. Incontinence or leaking could be an indication of cord equine, but also an infection. Burning sensation, again, we think about infection. Progressive pain and weight bearing could be a fracture, avascular necrosis, or infection once again. And any signs of any weight loss recently, night fevers, lethargy, these could be all indications of something a little bit more sinister going on. So I think we just need to be alert that there are other things that can go wrong. Now that really is a brief summary of the subject of questions I asked. There are probably a lot more you can ask, but within the time limit we've got, and we need to be observant on that, I just try and ask the priority questions, give me an idea where my objective exam is probably going to channel its examination towards. It's important that we probe the patients, we ask the patients, because they normally can tell us where the problem is. So what we're going to go through now is an objective examination. Now, arguably, as we said in the subjective, many of the orthopaedic and manual tests when it comes to the hip joint still remain unreliable, mainly due to inconsistencies in the research, the quality of research, and obviously flaws within the methodology of the research. And the sensitivity and specificity of these tests, unfortunately, are flawed because of that. Therefore, a lot of tests that you'll see today will just be the very basic tests. Certainly tests that tend to be a little bit more reliable. However, the only real way of knowing what's going on inside the hip, as I'm sure you know, would be hip arthroscopy, and to an extent maybe an arthrogram or CT stroke MRI scan, but even these are 100% reliable. But that's why we build up a picture from the subject onto the object to give us an idea of what's going on. So one of the first things we look for is just observation. So I always like to look at the patient as they go from a sit position to a stand position, and their gait coming into the consultant room, because this tells us a lot. If they're limping, it could indicate maybe some severe degenerative changes. We look for any obvious Trendelenburg, where the hip is actually hitching down. We look for any clinical foot drop, which may indicate maybe some form of cord compression, some neurological factors. And again, when they come in the room before they sit down, I just generally just have a look, see how they're standing in front of me in terms of biomechanics. Q angle as an example, the way their knees are, the way the femurs are, where the shins are, and whether they're pes planus as well. All these give us an indication of what's going on. And if we can't clearly see that, maybe because they're wearing trousers or they're wearing a dress, then during your objective examination, following your subjective, I'd ask them to get some shorts maybe or some underwear so I can see exactly what's going on and what their biomechanics is like. Once we get them on a couch, there's maybe 3-4 tests that I like to do just to give me an indication of what's going on. The first is just a simple leg roll. And what that would tell us is what's going on inside the actual hip, because it's a passive movement. So we've got Gerard here. So if I just show you on Gerard, so I just place one hand on femur, one hand on the shin, and I'm just rotating. And what I'm feeling for is the end feel. Does that feel nice and springy, which is a capsular end feel? Does that feel slightly springy, but slight edge on it, because there should be a closure just on the lateral rotation of the hip, internal rotation of the thigh, to suggest that this hip won't go any further. And again, it should be a bit springy. If it's firm or hard, that could already indicate some degenerative changes within the actual joint. So a general leg roll can tell me an awful lot. Also, just looking at the leg themselves, do the legs look equal? If one is externally rotated and slightly shorter, you'd be thinking maybe some form of subluxation, even though it's rare, dislocation, or even a fracture. So general leg roll, passive movement, intracapsular, looking for any potential restriction in movement. The next thing I tend to do is hip flexion with rotation. And again, that just gives me an idea of range of motion, but again, I can feel what's going on. And because now I'm bringing the knee up, so the femur now is closer to the superior acetabulum, I'm arguably testing the superior medial rim of the acetabulum further, which we know is common for osteoarthritis and femoral impingement. So a nice little rotation again, feeling the end feel of the capsule, should be nice and springy, but again, if it's hard or really firm, it could indicate a pathology actually within the actual hip joint itself. And then I tend to do a hip quadrant, a maiden hip quadrant. Now, I should be on the other side, but I'll just show you so you can see what I'm doing. I just take the hip into flexion. I'm looking at the patient's face for any grimacing while I'm doing it, and I say to the patient, if you get any problems, let me know. Now, there are two things you're looking for here. Pain, and you're feeling the actual joint. The joint surface should be nice and smooth. So as an example, on Gerard, I'm going to take him into hip flexion. I'm going to add some slight pressure, hence why you can tell already it's not very reliable, and we rotate inwards. And we do this nice anti-clockwise direction just to see if there's any pain, any grimaces on Gerard, but more importantly, I'm feeling that smoothness of the joint, and it should be nice and smooth as I'm going round. If there's a judder, and he's grimacing, that may indicate some degenerative changes or some acetabular rim damage, whether that be some form of femoral acetabular impingement or whether that be just simply some form of inflammation of the capsule. Likewise, if I passively cannot take him past 90 degrees, if I physically cannot get in there, that could indicate some form of slipped capital femoral epiphysis, say some form of avascular necrosis, because hip joints that are really damaged do not like going past 90 degrees, let alone the fact that they can't even rotate as well. So we look for these movements. The next thing we're going to be looking at is just any obvious Trendelenburg. And the way I look for Trendelenburg is I will just palpate the PSIs and I ask them to stand on one leg, and the side that drops down, the weight bearing side, normally indicates some sort of glute med wastage or atrophy, which again you see more in patients that tend to have more chronic hip pathology. So again, I think more towards the degenerative side. And then finally, just to make sure that I'm testing the nerves around the area, I would do a straight leg raise test to see if there's any problems in the back part of the hip. So we're looking again for piriformis type pathologies, as well as sciatic nerve pathologies. So an SLR on Gerard there, and if he says it's sore, that would be an issue. And obviously we dorsiflex to be sensitive. or we can rotate the hip in the SLR position again to stretch out the piriformis muscle. So these are general tests that I would tend to do. You could do an EFAI test, femoral acetabulary impingement test, but in my humble opinion, it's not always 100% reliable. So again, we take the leg up and we take it into the 10-2 position, it going towards the shoulder, which may indicate an FIR, but we've got to appreciate that could be arthritic. That could be any intracapsular pathology, generally. So again, it's not specific enough for FAI. The next thing I would tend to do is palpate. Now, I find palpation sensitive and specific about the fact there is this discrepancy with intra-assessor reliability. How I do it and how someone else do it may be different. The amount of pressure I apply, the anatomical position may be different. So we've got to appreciate that there is an essence of unreliability, but it's quite sensitive and specific. Osteitis pubis. So we know there's inflammation on the pubic symphysis bone, so just around there in the centre. And direct palpation of that region would be sensitive. So I'll normally go to the umbilicus and I'll step down, explain to the patient exactly what I'm doing. In particular, when you've got ladies as a patient, I'd bring a chaperone in and I would go down straight to the firmness of the pubic tubercles, and that would be sensitive if it was osteitis pubis. If you then go 1 centimetre lateral both sides when you're on the pubic symphysis, so there's the pubic symphysis there, and then lateral, just there and there, are the tubercles, centimetre lateral. That's where several connections occur, including the attachment of the inguinal ligament, the conjoint tendon, which is a branch of the internal oblique, which we see commonly pathologically in patients with Schwartzmann's hernia. Excuse me. The parts of the adductor longus can connect to the pubic tubercle, as well as the rectus abdominis sheath. So there's about 4 or 5 structures in that area, but specifically, palpation of that and tenderness may indicate some form of Schwartzmann's hernia, and they normally are tender if you get them in within 24 to 48 hours of a flare-up. Outside of time, rarely is it that sensitive. Next things I would palpate would be the actual tendons, primarily around the hip, that tend to give us problems, muscular strains and sprains. So rectus femoris, coming off the anterior inferior spine, which will roughly be there and be quite tender, especially in the upper 1/3, and also the adductor longus tendon, which is the most common adductor tendon, as it goes up and connects into the inferior pubic rami, into the rib, and parts of the pubic tubercle as well. So for this, I then take the leg outwards into the kind of Faber's position. We've got that nice, beautiful femoral triangle, superior border being the inguinal ligament, medial border being the adductor longus, and lateral border being sartorius, and you'll feel the medial border being the adductor longus tendon be quite sensitive and sore if you was to palpate. Now you could say, just resist adduction, that will tell you, but no, that does, yes, suggest an adductor longus tendon, but it also could be osteitis pubis, it could be a Schwartzmann's hernia, and it could be actually intracapsular, because as they're adducting, they're increasing the pressure within the hip joint, so that sometimes can be sensitive. Hence why that test isn't always the best test to do, but what you can do is do that test and ask them to pinpoint exactly where the pain is, or you palpate directly as they're doing it. So again, palpation. So adductor longus tendon, and it's going to occur, it will occur in the upper 1/3 of the adductor longus tendon, as does rec fem. So they're normally the muscular strains and sprains. I would always feel the glands in the femoral triangle. Again, if they tend to be enlarged on one side compared to the other, or even bilaterally, that may indicate some form of infection, some form of chronic inflammation, or even maybe something a little bit more sinister. So we just need to be aware of that. I do check the lower abdominal region, being below the belly button. Again, I palpate where the ovaries would be on a lady, which is just slightly medial to the anterior superior spine, just looking for any tenderness, any lumps or bumps, which may indicate a cyst. Above the pubic symphysis is the bladder. I will just palpate around that to see if there's any distinct tenderness there, in particular that's referring there. And we've got to appreciate that the bladder, as the urethra, which connects to the kidneys, we know that the kidneys and bladder can refer to the posterior part of the hip joint as well, around the kind of SIJ region. So that's why I just have a general palpation of those particular areas. I'm looking for anything potentially that can refer downwards. And then lastly, I would just have a little palpation of the greater trochanter, just around there, we're looking for any potential tenderness which may indicate some form of bursitis or even a tendinopathy. If you go around the lateral side, so to find it, I normally just place the palm of my hands, the side of the thighs, and just say to the patient, I'm just going to work myself up until I see a bony lump, which is your hip joints. That would be where the greater trochanter is. If you go slightly posteriorly, you will find that's where the tendinopathy would be if it was sore. And that really concludes the manual orthopedic testing of the hip joint. You can see that I've done a huge variety of tests for the reasons I explained beforehand. But again, with the subjective exam compounded by what you've done additionally today, that should give you an indication of what could be going on.